AST. How many people are members of the AST, by the way? If you're not, please join the AST. The AST needs you, and I think that you'll see lots of changes with the AST over the next year. There's really a whole new board, a group that is committed to sort of redefining. Not only is sort of adopting the things that the AST has done over the years, and helping to make some changes that will lead the AST into the future. But our next speaker is Emerson Kerr. He is the Vice President of Market Development with Knox Medical, and he is also one of the co-hosts of the very popular, I've heard, podcast called Sleep Tech Talk. And more importantly, he's one of my best friends in the world. We've worked together for years and years. Worked previously at restaurants together, and we get to spend a lot of time talking. And we don't get to see each other very often, but we do get to talk a lot. So please welcome Emerson Kerr.
Yeah, for three guys that don't know what we're doing, it's kind of crazy how the podcast is done. It's been crazy. It's been fun. I mean, my whole career is like that. I'm a redneck from South Alabama, and I figure at some point they're gonna figure that out, and it's all over for me. But 25 years later, I'm still pretending. Just to kind of piggyback on what Robert said, the AST. Honestly, we were not delivering to anyone any value whatsoever. And we made some massive changes. We reunited with the ASM. So they are our management partner now. So what does that mean? It means I get to advocate for you to the academy. We have a direct line to the leadership. I talk to them every week about something. So to give you an example, as the new codes come for home testing, I was already advocating for how we were going to make sure you were educated on what the changes were going to be so you could plan. If we were not at that table, they were only going to tell your doctors and not you. That's what we do. We advocate for you where it matters, when it matters, and how it matters. And it's not always easy. Sometimes they're hard conversations, but that's our job. That's my job. And it's fun. Don't get me wrong. I'm honored to be in such a hot spot, but that's what we're thinking about. That's what we do. So if you wonder, what do we do besides education? We're arm wrestling and arguing and all kinds of things to make sure that sleep technology stays vital and centered to everything. And that's fun. So yeah, there's a couple of things I do. I don't have a whole lot of downtime. But it's, what I've also learned is that the busiest people make the best volunteers. That's been one of the things that's bizarre, because if you look at our board with the AST, Robert's on the board, Massey Harrington from Atlanta is on the board, Sarah Brenica from Northwestern in Chicago is on the board. Those three people are the three busiest people I've ever met in my life. They work 12 hours a day, sometimes 16 hours a day, and then volunteer. And so when you say I don't have time, I just sort of smirk. I'm going to go from this meeting back to my hotel room and have a 3-hour board meeting and fly home tomorrow morning, because that's important. What we do is important. And so as we go forward in this conversation today, the thing I want you to hear is really what the future can be about. When we hear things like AI, we kind of freak out a little bit. How long do you think auto scoring has been around? So I had my first Sandman unit. I bought it from Gina Hetherington. Wow. In 1999, 2000, somewhere in there. Guess what they had in the Sandman PSG? Auto scoring. It sucked, but it wasn't very good at all. But guess what? That's when it happened. There's a little company that used to be really big in this part of the world called SleepNet. They had this really cool thing called Morpheus, an AI. It was way ahead of its time. So it's not new. So when we hear this idea that this is new and it's big brotherish, or it's going to take my job, you got to think different. Because as we think about this, where we're going in sleep and in medicine and life, is an AI world. And so as we think about where we've come from, I mean, Dr. Rex Chafin and these guys who were our pioneers and really shaped what we do were so important. And I remember working on a paper machine like this. It was an old neon coding one there at Mobile Infirmary a lifetime ago. And it was fun. I remember when we went from paper to digital, one of the first things I got complaints about was, how will I know when they turn over? How will I know when the heart rate changes, or if they have any kind of PVCs, or if they have a seizure? I can hear it. I can hear the pins change. We even asked, can we have pin noises with this? So, but we adapted, right? Things did change. But there's other changes that came along the way. Back then, we did 2 nights. And boy, we thought we did great medicine. We did do great medicine where we were. But then came the issue of maybe having to do split nights. We were horrified. And then we were having to scroll on the fly. Oh my gosh, we're going to compromise healthcare. And yep, we did it. We figured it out. You know, things kept changing. And then mid-2000s, we've got home testing. Oh, it's going to kill sleep. And in some parts of the world, it did. And the reason it did is they didn't plan. And they lost. And that's the key message of what happened with home testing, is that the people who really fell apart and didn't last, didn't plan. And they didn't adapt. Now look at where we are now. You're all here. We're still doing sleep. 85, when I started at Respironics in 2001, I used to go around the country doing this all the time. It was me and 2 other people were the clinical people for all of Respironics back then. And I remember standing in front of rooms and saying 90% are undiagnosed and untreated. Guess what the number is now? It's 85. Oh, we made a big dent. You know, well, of course, we're all still eating biscuits and gravy in the South, so that doesn't help either. But the problem hasn't changed much. When we look at adherence to CPAP, it hasn't changed much. I mean, gosh, when I remember being in my lab at the Mobile Infirmary, and the 7 sizes of gold seal masks, they were so freaking awesome, man. I had all the purple boxes on the shelf at the top. I mean, it was fantastic. And that thing weighed like 10 pounds on your face. It was ridiculous. But guess what? Adherence is almost the same. It's still not that great. We heard a little bit about that this week. But the size of the problem hasn't changed. Now, things we're learning, though, is how it's connected to other pieces. That's what we're learning. And we're learning some things now that are really opening our eyes to subtypes. And that's where AI begins to make a difference. Because one of the things we're going to see, especially when we get to January of this next year, are these coding changes for home testing. We're going to see, we don't know what it looks like yet, so let me tell you that. We won't know, and if you don't know much about this, what is going to happen is that CMS is going to give us new home sleep testing codes. We'll find out what they are next July of 2026. There'll be a grace period or a comment period, it's probably a better way to say that, a comment period, which really doesn't mean anything. It just means we get to all vent about what we don't like and they pretend to listen. And then in November of 2026, the final information will be published with, you know, what those values and reimbursements will be. So right now we've got 4 basic types of studies, right? All the way down. But the thing is, when we think about treatment, we've always kind of been CPAP. Now we've heard, you know, we've got vendors out there that provide other solutions, but the reality is that CPAP isn't for everyone. There's new research out of Harvard that says it can actually be dangerous for some people. And that's again, us learning more about these subtypes. And that opens our eyes to some things, because I was always that guy. I mean, especially working for Respironics for so long, you know, somebody couldn't figure out how to use a CPAP. I think, man, we got 20 ways to figure this out. Let's get at it. But the reality is it might not be for everyone. And we've got to understand that. And as sleep technologists, I see that as an opportunity. I don't see that as a threat. If I can do a better job helping my physician and my patients figure out a better therapy for the patient from the information we get from a sleep study, that's having value and that's having purpose in life. So, you know, when we think about what hasn't changed, that's incredible. I mean, Dr. Weaver is one of the leading voices when we talk about adherence, and she's one of the ones that created the the FAAST questionnaire for quality of life. So definitely somebody that's at the forefront, but their treatment options are changing. And that's fantastic. I mean, oral appliances are lighter and smaller than they've ever been. We've got all kinds of electronic solutions for stimulating the airway, the pharmaceuticals, the GLP-1s, and what we see coming from Apnimed and what it could possibly do. These are all the new world that we're living in. But one of the things that if you ever have insomnia, read. There's a book that will help cure that. But it's Thinking Fast and Slow by Daniel Kahneman. He's passed away, but he won the Nobel Prize for economics as a psychologist. But he has this thing called a sunk cost fallacy. And the sunk cost fallacy is a situation where you've invested in something, you've invested a lot, it's failing, so you invest more to try to improve it. It continues to fail. Well, now you're married to it, so now we got to continue to invest in it. Well, a lot of what we do right now is that, particularly with CPAP, is we believe this is something that we should be doing, but we have to take a step back and ask, is it really the right solution for our patients? So this is where artificial intelligence can begin to inform us and give us insights. And that's really what I want to talk about over the next few minutes. Is there's lots of different terminologies that all are basically saying the same thing. At Sleep, a little over a year ago, Dr. Toddy, I'm not going to try to say his real name, but we call him Dr. Toddy. It's at the VA in Milwaukee. And then Massey Arrington, our president-elect for the AST, and AST board member, really debated about what were the pros and cons of AI. And when you look at it, and I'll focus more on what Massey had to say, is you still have to have the oversight. And that's not really a negative, but we were really talking about some of the things that can play into this. There are challenges when it comes to AI. And I think what that requires of us is to provide our own level of scrutiny as to what we're looking at. Anytime someone presents something to you, you want to have a skeptical eye. Here's my current pet peeve. We have this solution that's FDA approved. You know what FDA approved means? You ever seen an FDA application? It basically, an application is, I've got this new tool, and then I'm going to compare it to one similar to it and say it performs like that. And so the FDA looks at my paperwork, and they look at my data, and they look at the product that I'm comparing it to and go, yep, it's going to do work like that. That's all that means. So when you hear FDA approved, use a degree of scrutiny. Don't get too excited. Ask for proof. Demand to see some data before you take the leap forward. Because even in AI, we need to have that kind of mentality and scrutiny that we bring into it. But I love this statement here. I mean, think about this right now with ChatGPT. You're writing a note to someone. Now, if you're like me, English is really not my first language. It's something Southern. I don't really know what it is, but I am not a great writer at all. But buddy, if I'm writing something and somebody else is using ChatGPT to write the same thing, I'm an idiot for not at least running it through the machine to make sure it sounds better, because that's really the world at the moment. So guess what happens just in something that simple? If I'm writing an email to a doctor, say at Mayo Clinic, and somebody else writes one, it's really smart if I just run it right to that machine and make sure it sounds sharp, because that could be the difference in how it's perceived. So it's really, this statement speaks volumes. I mean, and the original one had to do with physicians. The physicians that aren't using it will be replaced with the ones who are. It's the same thing with sleep techs. We've got to think in those terms that if we're not using AI to our advantage, we will be replaced by the ones that do. Because there are really great benefits to it, and we'll see that as we go forward. When we look at the timeline of artificial intelligence, it goes pretty far back. I mean, I remember the first time I ever saw a movie about it. I mean, it came out about the year I was born, in 2001 Space Odyssey. That was an AI. Of course, it was a bad AI because it killed everybody. But, when we look at the timeline of events on AI, we can see how it's just gotten better and better and better. And it's certainly not something to be afraid of. But let's talk about how it comes into being. The first part is really understanding that classical programming is one where we have a set of rules that we program our phones or anything like that with our computer at work or home. And what happens is the next step is it's just classical programming. Rules and data into the device give us answers. Our calculator works that way, right? And that's our typical programming model. But when we look at it from the standpoint of how machine learning fits in it, it's putting the data in with answers so it can begin to churn that, work as a machine to then give us the set of rules. Think about a sleep study that way. Why would companies that have AI need scored sleep information? They take scored sleep studies and they put it into the algorithm so that it begins to learn how to score a sleep study from a human. That's why a poorly scored sleep study is going to give us a bad AI. It can only do what it's trained to do. It's not smart enough to go, oh, wow, that actually wasn't a K complex. It's going to actually perform based on the information put in it. And so what ends up happening is you have the machine learning that ultimately ends up driving what would be classical programming. So there's a process to how this happens. And so here's an example of how this could turn into some simple but bad information. So we compare puppies and cupcakes. Very big, very different. But if we don't do it the right way, could be a tasty puppy. I don't know. That sounds awful, doesn't it? Same thing with cats and croissants, right? We could describe them poorly, and now we're mistaken with what we're looking at. And it can be that simple. But that's why the data matters. That's why the organizations that are doing AI, it's on them to, and even on us. The onus is on us as customers to challenge the data behind what they're presenting to us when they say, we've got this kind of AI. Well, how did you come to these conclusions? How did this work out? So, I mean, these are fun and silly, but at the end of the day, the Academy's on this. They've had a task force behind this. We've got, the rules that they base it on, but let's talk a little bit about what it is. And that's really, it's not the sci-fi that we hear about, like in movies with Terminator, and I'm sure you've heard that example before, but that's sort of where our minds go, as we begin to think of the worst case scenario. It's going to take over and run the world, but it can only do so much. Now, there is some aggressive models now that are very, almost independent thinking. But what we're dealing with in medicine is certainly not that. Very governed, and it has to be, because we're dealing with patient data. We don't want AI that's going to be able to do something beyond just the basic rules of even HIPAA. So it works inside of a system that's very well governed. So when we think of some of the AI-enabled devices, these are just some of the terms to help you understand. There are some that learn continuously. There are others, and mostly what we see in healthcare are types where they have fixed periods of time. So if you maybe are working with a company that has AI, what typically happens is it goes through a process of programming. So that what happens is they have what are called releases. You've seen them before with your sleep systems. They've had a release or an upgrade, right? With a sleep system that you use. Well, the same thing happens often with AI. You'll have an upgrade with it. And sometimes that upgrade might even require more FDA approval. But at any rate, these are some of the things that can happen with it. Autonomous could be that there's a human in the loop. It's extracting new information. You've got all kinds of things, but the governments are on this. They're regulating it, and so is the Academy. So when we look at the US and Canada, we've got regulatory bodies that govern it. It's not a runaway system. But there are limitations to it. When we think about it, is the task at hand easy? Is the data available and sufficient to train a model? We'll look at kind of how that works here in a few minutes. But it's important to understand how the model can predict what it's doing. And where that comes back to is even the data. Is the correct data being input? That's an important question, and one we have to ask when we're listening to presentations about it. What about populations? I mean, think about, here's one example in sleep of how just a current rule set works against us. The original studies about OSA, Do you think it was a diverse population? There were guys that looked like me. White, BMI greater than 30. Yes, I am. I know, I'm proud of it. I'm working on it, me and Wigovie. But the reality is that's why when we do sleep testing on women, we see different results. We don't qualify so many women that have sleep disordered breathing because the rules were made for guys that look like me. That's a bias. It's a bias that we're all trying to work on, but that's an example of how bias can influence a decision process. So when we think about that, that's important as we think about the populations of patients AI is looking at. So that as it begins to analyze it, is it looking at all genders? Is it looking at all races? Is it looking at all types? All of that ends up mattering because we could end up with the same series of biases that don't get us any further. Now, that's not what's happening, but that's just a good example of where that's gone wrong. So when we think about the process of programming, what basically happens is you've got sites where data is extracted from, sleep labs, sleep testing sites, whatever you want to call it, and that data is put into the training and algorithm to train it and tune it. And then what happens, it goes through a validation process. And that validation process is basically, okay, was the spindle a spindle? Was a K complex a K complex? Was the delta wave the microvolt that needed to be? All of those things end up mattering. So, and that's part of the analysis of validating, the system that the AI is looking at. But then it's got to be compared against real world. Once it's been through that validation, it's got to be evaluated even again to make sure that what we've got is suitable. And that really is ultimately going to tell us, do we have good data? And that's an ongoing process because you're constantly tuning the algorithm to make sure it has it. And we're seeing this in all kinds of ways. It's not just sleep. We're using AI to mine systems, to look for patients. I mean, think about it. You've got, just in some of the systems that you work at, you've got thousands and thousands of patients. What if they begin to see a thread that's running in a certain patient type? Maybe it's you've got a certain age group or a certain series of symptoms. And now that series of symptoms leads us to an endpoint that says all of these patients with these characteristics under these circumstances tell us this about this patient group. And now that develops what we call a phenotype, a type of patient that we can look at. So when we think about AI-enabled devices, like we talked about, this is an article the Journal of Clinical Sleep Medicine has published. A great group in there that all great thought leaders that I highly recommend you follow. But they came up with a SWOT analysis that really walked through the strengths, weaknesses, opportunities, and threats of what AI can be. Now, remember, if you're not familiar with a SWOT analysis, strengths and weaknesses are internal, opportunities and threats are external. So as we look at the first series here with strengths, what could be helpful internally to sleep with AI? So we've got efficient analysis. That's an easy one. Obviously it's crunching lots of data. Complex patterns, I just mentioned that. Looking at complex patterns to find that theme. Automation of sleep scoring. We've already are familiar with that. We kind of opened with that analogy. Personalized approaches. We've heard about precision sleep medicine or precision medicine. That's where we're able to personalize it. And my good friend, Dr. Lance with React talks about multi-modality care. So that now you're able to pull lots of pieces in together to have that precision medicine. And then the longitudinal monitoring. Over time, how is this going to look? If we're able to follow thousands and thousands of patients, and now we can see what some of these endpoints look like after having this preventative medicine or this using predictive care, what will that ultimately look like? And then our cost effectiveness. When we look at weaknesses, well, is the data set good? Is the training good? Do we know that what we got was good data? What if we don't have standard variable? I know the Academy is already working on that. Generalizations, bias, all of these things begin to be things we have to think about. And of course, the Academy is certainly doing that. But when we look beyond that and we start thinking about opportunities, maybe it's improved access to patients. You know, one of the things that I know Robert and I have championed for years is inpatient screening. It's hard to do. You know, when you go out and you say, I remember the first time I tried it at a hospital in Montgomery, Alabama, we did Berlin questionnaires and we said, for, you know, if you'll just do this to case management and you get 3 or higher, just send a fax to the sleep lab. Holy smokes, man, that fax machine was burning up. We were like, stop, this is not a good plan. Everybody has sleep apnea in this hospital. But that became part of the challenge. How do you mine through all that? How do you look through all these different patients to triage it and say, these types of patients should actually be seen and be evaluated for possible sleep testing? So being able to really work through that is a possibility with this as well. Accuracy and objectivity. I mean, it's easy for us to bring our bias into something when we just talk with a patient. But ultimately, I think its opportunities are, how can we find patients that have sleep disordered breathing that possibly could be missed? That's really it in a nutshell, in a cost-effective way, because it's not like our budgets are getting bigger and bigger and bigger. Every year they're squeezed a little bit more. But then there's the threats. And that's the part where we kind of cringe a little bit. We become over-reliant on it. I mean, we heard, you know, Farah talk about this, and that is, and I say this a lot, people take care of people. That's why I'm a believer that sleep technology is here to stay, because at the end of the day, we still take care of people, and you can't replace that. But you can use these tools to better understand the patient in front of you, and that's critical to all of this. You can still have false positives. We see that already. I mean, most of the technology out there, it's not 100% accurate in what its capability is in being able to diagnose a patient. So you're still going to have false positives and false negatives as a part of things. We have to think about HIPAA compliance. That is the safety feature. Will the technology be that? I mean, we have a lot of safety nets built in to help with that. So there's a lot of different things that can be threats. But, you know, and there are articles that talk about how you can understand what these technologies are doing and how they're learning to finish that. So that kind of gives you the framework of what I want to talk about next, and that is really, what is precision medicine? So we know how AI comes together, kind of at a 30,000 foot level. But part of our challenge is what we talked about in the beginning. We kind of use a sledgehammer approach a lot of times to sleep. We look at this. I actually said this on LinkedIn not long ago. I was talking to Emma about this. It was talking about a particular doctor who's a friend of mine. And I said, you know, he doesn't qualify patients, he diagnoses. It's a little cringy, right? It's a little on the edge of that one. But are we doing that? Are we diagnosing patients, or are we just simply qualifying? Because there's a difference. I mean, there's 84 sleep disorders. 84, not one. 84. The doctor I trained under was fantastic, because when I would look at his axis and his interpretation, it was full of recommendations based on what he analyzed from the sleep study and from the visit with the patient. There was never one disorder on the page. And so when we think about what precision medicine can be, I think it can bring us back there and bring us back to a place of really doing real diagnosis. Because at the end of the day, we're trying to solve a problem. I mean, when somebody comes to get a sleep test, I hope you know that's a big deal. I mean, how many of you love going to see the doctor? Said no one ever, right? So I hate it with a passion. But guess what? If somebody goes to the trouble to finally have a sleep study, it's a big deal. It isn't small. I mean, think about yourself. How many of you are just dying to go have a sleep test? No one in here. I mean, sure, you're curious, but do you really want to? Especially in front of your colleagues, wouldn't that be awesome? No, not at all. So I think we have to think in terms, we can't lose sight of that people who come see us are trying to solve a problem, because both of these people are suffering in this picture. One of them probably has hypertension, is probably going to develop diabetes, is likely going to develop heart failure, has a whole host of challenges that he's going to face. She, on the other hand, is miserable, She's not sleeping. She's got fragmented sleep. She might even have sleep disordered breathing too, but she doesn't know because she can't sleep. So that's part of what's in front of us. How can that change? Well, one of those things that we talk about often is what we can do with endotypes. Endotypes is there's a way of thinking about that is think of OSA and thinking of OSA subtypes, just for the sake of argument. What if you had these other features of sleep disordered breathing that could tell you a little bit more about what's going on with the patient other than just an AHI? Because most people agree AHI is just simply not conclusive. It's not enough, but it's the only thing we really have at the moment. So we use it the best we can. But what if we could actually look at waveforms and deduce from that certain types of breathing disorders that might help us? One of the things that we're able to do with certain types of RIP technology is look at breathing from this standpoint of endotypes. What's the collapsibility of the airway? What's the muscle compensation regarding it? The loop gain, and then finally the arousal threshold. And we're going to walk through these here for just a few minutes. So the pharyngeal collapsibility part. That's a pretty interesting one. We're all kind of familiar with that floppy airway. Then we've got the dilator muscle aspect, which could be a factor both awake and asleep. The arousal threshold, that's a little easier for us to wrap our head around. And then loop gain. And all of these will make sense as we go along. But when we think about the collapsibility, it's that increased tendency for the airway to collapse during sleep. You know, the first time I use this example, the very first time I did a presentation 25 years ago, and I thought of collapsibility from the standpoint of a straw. I remember the very first time I had a Wendy's Frosty. It's ice cream in a cup, right? I'm really bright. I thought, that's a milkshake. So I take the spoon out, I stick a straw in, I try to suck that ice cream through the straw. What happens to the straw? Collapses. I'm really bright. I learn fast. So that's what essentially happens with sleep apnea. We have a flimsy straw. We have a flimsy airway, and the higher that collapsibility is, the more unstable it is. And we have to think about that because the treatment options we begin to think about choosing could be really important the more collapsible the airway is, right? So that's important. The next is our dilator muscle activity. And so when we have that, the failure of those muscles, and that's our support structure to provide the normal baseline level of activation and a reflex, increase activation as ventilatory drive rises with obstruction. So a low reflex compensation may be consequent to reduced neural responsiveness to stimuli or reduced neuromechanical activity. So now we're getting down to the very functionality of the airway all the way back to the nervous system, its ability to drive and control the airway. That's way beyond AHI. So the next one is a lot easier to wrap our heads around, up the arousal threshold. So a great way of even seeing this one is, all of us can probably identify with it at some level. Baby's crying. Mom and dad are in bed. Which one wakes up? Guess who probably has the lower arousal threshold, meaning it doesn't take much to wake her up? Mom. I think it's somewhat evolutionary. I think we all kind of are built in with that. Dads are like out cold. We're sleeping right through it. High arousal threshold.
Dad really woke up.
That's right, brother. We got to maintain. We don't have much control. We got to pretend like we have some somewhere. So, but think about this though. You've got a patient that, you know, gosh, they got this incredible AHI. They've got this incredible hypoxic burden. They need CPAP, and everything is so uncomfortable they can't fall asleep with their mask on. Well, if they have a low arousal threshold, meaning everything wakes them up, everything's going to wake them up. Inspire is going to wake them up because their system is built in a way that they're going to be triggered to arouse because they have this low arousal threshold. So that begins to give us some insight into, oh my gosh, I've got to be thinking strategically about whatever therapy I provide to the patient with that. The last one I find fascinating. When I was with Philips, for a hot minute, I was the product manager for the BiPAP Auto SV. So I really got into the nuances of ASV and complex sleep apnea and Cheyne-Stokes. Well, loop gain fits right in that discussion, right? Because what happens in loop gain is kind of cool, especially if you're a nerd like me and you're thinking about why breathing happens this way. But Dr. Atul Malhotra has a great example of high loop gain, and he uses an air conditioner in a house, or it could be a heater. But anyway, just an internal system, and the temperature changes a little bit in the house. Maybe it gets hot, goes up by a degree. You know, you had it set on 72 and it goes to 73. And instead of the air conditioner kind of coming on a little bit to cool the house down, it goes wide open. Fans wide open, it's blowing as hard as it can, and then it shuts off. And the house warms back, and it blows wide open and shuts off. Well, think about Cheyne-Stokes respirations. You've got this crescendo breathing, a hyperventilation, then a hypoventilation, a hyperpnea and a hypopnea, hyperpnea and a hypopnea, and a hyperpnea and a hypopnea, right? It's that crescendo decrescendo breathing. Well, guess what? That's a loop gain issue. And then when you've got a long loop gain, like you see in heart failure, you're going to see that crescendo, decrescendo, central, right? Crescendo, decrescendo, central. That's a loop gain that's tied back to heart failure. And so we begin to understand these things. We begin to piece this all together and see there's a picture here with these subtypes that are telling us about breathing. But we can only do this with AI. We can only see these nuances with that. So why does all this matter? It matters because as technology changes, as needs change, we can do better. We know better, we can do better. So let's think about another dilemma that faces us. AHRQ, if you're not familiar, was a little thing published or sponsored by CMS that basically said CPAP doesn't work. Sleep is inconsistent in how we're diagnosing patients, and this whole business doesn't work. Now, part of it is because of how we do it. Everybody's got a different set of rules. We're not approaching sleep the same way, and we're also trying to put people on therapy they don't need to be on. So that's going to be a complicating factor. So what can help with that? Well, we can think about other solutions other than CPAP, because maybe that's it. Somebody to follow that's talking about this right now is Ali Azerbaijan out of Brigham at Harvard. He's got some great work on this right now. I actually talked to him on the phone yesterday. He's going to be on our podcast talking about hypoxic burden, but he's got new data that talks about the dangers of putting somebody on CPAP who doesn't need to be on CPAP. We've got to be thoughtful about that. It's new data, it's new research, but it's stuff that's helping us understand. Maybe I should have put that person on oral appliance. Maybe I should have put that person, we should have explored surgery because CPAP wasn't the right solution. But that leads us back to, okay, well then, how do we figure this out? We've got our phenotypes, we've got our symptoms and demographics that help paint this picture of what these are going to be. One of the people that's also great to follow is a researcher out of Australia named Danny Eckert. Dr. Eckert has really kind of broken this down nicely, and being able to look at all of these things that I just talked about, categorizes them slightly different from a semantic standpoint. But you can see that what we've got are the four areas we mentioned before: the dilator muscle, the respiratory arousal, the anatomy collapsibility, and the loop gain. And you can see from that, like the loop gain picture there, it looks really familiar to like what Cheyne-Stokes looked like. And then you've got, all of these really telling that story of what is going on with the patient. And so what he's done is put them into these four pieces. One is P-crypt. Now, that sounds maybe a little bit odd. And one of the things I like to use with that is an old slide I used at Respironics for a long time, and it was really on how the auto CPAP with Respironics work. And it's the same thing, I think, with the other CPAPs as well that have an auto is is where is that collapsibility of the airway? Where's that critical pressure that opens the airway up? That's P crit. And so you've actually heard about this for a long time. Because if you were ever in any of these meetings and heard somebody talking about how an auto-titrating CPAP worked, they probably used that term to describe some of the functionality of how those work. But we don't think about that when we're titrating a patient. We're not going, ooh, I wonder where the P crit is. We're actually just looking at that AHI and trying to raise the pressure till we have, you know, the good stages of sleep and a good AHI as a part of that. But when we're looking at this at a very granular level, now we're thinking about that. And we can see that through it. Here's another example of loop gain. And you can see kind of Dr. Malhotra's example here of the patient over breathing to compensate for the event they experienced. Because remember, the body's always working to maintain homeostasis. And what does that mean? It's sort of like balancing a chemical equation. You know, so anytime the body suddenly goes out of whack, it's going to compensate for it by producing something else. A COPD patient has a high CO2. What does the body produce? Bicarb to balance the equation. When we overventilate, what is the body going to do? It's going to have a central to balance the equation. So when we think about these things, these are natural phenomenon, but what if we can have a better view of it to understand what can happen with the patient? There's our loop gain. So then we go back to Dr. Eckert. And what Dr. Eckert has done, and it's just an example of how to break down the palm scale approach to this. And we won't go too deeply in this, but I just want you to see it to understand that there are already people thinking about the process around how we can take this AI data and make it functional. Because that's sort of it. I was talking to Dr. Morgenthaler at the Mayo Clinic about all of this. I said, you know, the crazy thing about AI and these endotypes and having all this is it's like having a genie and not knowing what to wish for. Here's all this capability, and I go, what do I do with it? Well, that's where we're headed. And people like Dr. Eckert, and he works with the guys at Harvard, are really the ones thinking ahead on this and thinking, okay, well, how do I do this? And so when we break this down, you can see that what he's already thinking about is, you know, mandibular advancement, surgery, positional therapy, weight loss, and then really kind of looking at this as a total picture. Because now you got your loop gain, you got your arousal threshold, your dilator muscles, your repetitive OSA, all of that, you know, points back to this central part but what are the solutions that could potentially be a part of it? So one of them could potentially be like with the arousal threshold. You've got a patient, you find out after the sleep study they have a low arousal threshold. One of the potential solutions is hypnotic. What if the physician prescribed that hypnotic before you began to torture them with a CPAP mask, and now you've raised that arousal threshold, now they can go to sleep and begin to adjust to therapy. That's a potential strategy with taking AI and making it work for us. And so that can potentially change how we look at it. And it breaks it down even further. You know, there are going to be some classic CPAP patient, without a doubt. We're going to be going probably to CPAP with so many of those patients. But when we look down this scale here, you know, we can see that someone who has a moderate anatomical problem, the solutions open up. And now we can see that, you know, maybe I do need to look at mandibular advancement or surgery. And I think a lot of times we look at those as a safety net. Well, if CPAP doesn't work, we'll go to this. How many times do you find a patient after 90 days of being tortured is really excited about doing something else? That's sort of the model, right? Because Medicare gives us 90 days. And if we're not adhering at 90 days, if they have Medicare, we got to pull the CPAP, right? Well, now we're going to say, well, you know, after you've done this and failed incredibly, let's try something else. And now we're going to move into an oral appliance. Well, why didn't we start with this? Well, we had to try this first, and it's the standard of care. Now I get it, payers drive a lot of that. But what if you could start with the right solution? That's really what this is about. Instead of torturing somebody with something that was never going to work, what if we can go right to the right solution the first time? And that's really what we mean in all of this is, and in some people, particularly those with where they seem to have all four of these all at once, it can be a hot mess. But at least you know what you're walking into. Like Farrah was talking about, if you're on the DME side of this, and you in the sleep lab have called her DME and said, hey, listen, this patient's, they're a bit of a train wreck. You're going to have to spend more time on it. Well, now the DME can at least plan. We've got a patient, they've got a series of issues going on. We're putting them on CPAP. We maybe need to go to bi-level. We got to have an aggressive strategy. It begins to change the whole care plan. So now we're all working together. But instead of Kerr calling back to the sleep lab and say, okay, we're at 60 days. Emerson is failing miserably at this. What can we do? That flips the narrative and reverses this whole process. So now the patient's actually at the center of care again, because we're putting them first and saying, we've got a series of variables now that we know about this patient that inform us that we could have a better strategy instead of putting them through a hot mess, seeing them fail and quit, because that's what happens to most people. I mean, how many of you have ever slept on CPAP? How many of you, when you've had, the vendor says, hey, try this mask out. And you try it out and you go, oh, this is bad. You said, no, I'm going to stick with it and have one more night of this. How many of you go a second night? Nobody. Dr. Lance does. She's like that. But think about it. If you're not going to do it with the patient, no. So this is all about rethinking care. AI empowers us to go in a better direction to do that. And I think makes us better clinicians. Doctors Zinchuk and Yagi at Yale, if you ever get to hear Dr. Clark Yagi speak, he is awesome. It's funny. But when we think about these phenotypes, we begin to look at something really interesting. And I really like this next slide better because it is a little bit of what Dr. Ali Azerbaijan has talked about. And if you got to hear him, he actually did a webinar with Sleep World magazine. It was fantastic. But what I love about these two graphs here, or tables, however you want to call it, is you got two people with the same AHI. So let's say they both have a 30 AHI. One of them has really bad VSATs. We would say has a significant hypoxic burden. The other one doesn't. But guess what? If we're only looking at an AHI to make a decision without having a full understanding of the impact of their breathing, I would say that the patient on the left has a highly collapsible airway. Would I ever put them on an oral appliance? I would try not to. I mean, truth is, I might even put them on an oral appliance and a CPAP. Challenges with that is none of the companies out there have ever done any research to say that you should or could, even though we kind of know you can. But that's really where this gets really special, is if we've used our old system of saying, well, if it's an AHI of 30, let's just CPAP them and be done with it. Well, the guy on the right may not need it. Because even though the AHI is high, the DSATs corresponding with it are not that significant. Not saying that we wouldn't, but what it does, it opens up a conversation to think differently about the patient in front of us. And I think that's really what's at the heart of it, right? If we can do a better job in the beginning of recognizing that we've got a patient that looks different when we dig deep, then we might change what we do. So let's look at it from a value standpoint of endotyping with oral appliance. So this one is really interesting because when you've got somebody that has a high arousal threshold, or difficult to wake, lower loop gain, I mean, fairly stable person, they're going to do well with almost any therapy, but they'll certainly do well with this. When we look at it from the standpoint of efficacy, they're going to tolerate it well because they're not, especially if they don't have a highly collapsible airway. So we begin to see by endotyping that even with an oral appliance, we can be a little bit more strategic with how we're going to use it to manage the patient. But the one that's more near and dear to my heart is this one. I'll tell you a quick story about this. I was sharing it with Emma a little while ago, and if you're ever curious, it's actually featured in Sleep Review magazine. And I was talking to the editor, Sri Roy, and we were talking about the whole issue of women in sleep. And I said, you know, this frustrates me so much. I said, my wife is having to have a sleep study. She got a PPG, you know, pulse oximeter probe device, and it's come back negative. And I said, so I started thinking, what am I going to do? And then what I end up doing is saying to her, I said, listen, let's reach back out to the doctor. So her primary care orders the sleep study. She gets this device. It comes back negative. Now she's fit, but she has a little retronathia. Well, when we take this a little bit further out, I say, let's make an appointment with a sleep doctor. So she gets it. And of course, the clinical pathway is if we fail a home test, we should have an attended study. So the first piece of aggravation with this is I'm like, why does a woman have to pay more for her sleep health care than a man? So I'm already aggravated. And so she has her attended sleep study. It comes back negative. And so my wife's like, hey, you were wrong. I don't have sleep apnea. And that's how the fight started. So I said, no, honey, I would love for you to make an appointment. Just make an appointment, follow up with the doctor. Fine. So she goes. She says, Emerson says I have sleep apnea. He actually said that it's something called a RERA. I don't even know what that is. So the doctor's like, Emerson's right. You have upper airway resistance. You just don't have any desaturations where I can actually call it sleep apnea. Then she said, what's my alternative? He says an oral appliance. And she goes, he's right. Yes. One for Emerson. So at the end of the day, what also had to happen there? She had to have an advocate fighting for her. Because otherwise, the first phone call from the nurse practitioner about the sleep study where she says, you don't have sleep apnea, the conversation is over. I had to push it because the rules for sleep disordered breathing and sleep apnea that Gimeno put together a long time ago were basically on middle-aged white men with a high BMI. Leaves out a lot of people. But that was the study set. Did you know that women weren't included in medical research until the 90s? I learned that at sleep. That was a bit shocking. And for sleep testing or in sleep research, it wasn't until the 2000s. So guess what? We're looking at women the wrong way. So now I've still got to get my wife to get her oral appliance. She's an awesome patient. But the reality is at the end of the day, how many patients do we see who come in, they've got all the signs and symptoms of sleep disordered breathing. They may not have that BMI greater than 30, and we test them and they fail because we don't have enough information to help them. And we also are following a series of rules that were designed for different people. And we have to be mindful of that. So phenotypes in women brings up another issue. I mean, what is one of the classic signs? Insomnia. That's one of the classic signs of OSA in women. So these are all things that we need to continue to talk about, but AI helps with this. It helps us see at a different level, particularly arousal threshold. Women are going to they're going to be driven, their events are driven more by arousals than desats, right? So those are things that all of this helps with and is extremely important. Another article on women in sleep, this is a great one by Dr. Heidi Ryan in Sleep Review, if you ever want to see that. So we're getting close to the end. I know you're ready to go home. So when we think about these sub-phenotypes, this is a lot to read, and I'm not going to go through it all, but I think the thing at the bottom really captures what I was saying in the beginning, that mortality risk in women can be predicted from features of their sleep disorder breathing, but the critical measure is likely not AHI. Those are things that we're hoping change as we know more. So here's some examples just to give you how this can work. And I love these pictures. So I'm going to kind of turn around and walk through this. So let's look at this from the standpoint of diabetes. So this is where all these different things, genotype is something new in our conversation, but let's look at this from a diabetes standpoint. So we've got our genotype that kind of describes this at a very basic level. Our endotype is what we've been talking about, but in this case, decreased insulin production and insulin resistance is the endotype. Then we have the phenotype being the diabetes, but then the treatment, the insulin and then insulin sensitizing drugs. So that gives us a picture of it, but let's break it down to sleep. So we've got OSA, we've got a low arousal threshold, mild collapsibility. That's our endotype. We have a phenotype of just OSA with disturbed sleep. Now our treatment could be CPAP, but sedative hypnotics might work because of the arousal threshold issue we talked about. The next one could be an endotype of high loop gain. So you've got an OSA patient with cardiovascular disease, could be CPAP, but oxygen or acetazolamide might be alternatives for the patient. We already see that in our practices. The last one, moderate loop gain, moderate arousal threshold. OSA is minimally symptomatic. We might not do anything because now we know more. But in the past, or actually the present, we don't know that to make that decision. But this is where this really helps that. And then it really begins to inform us on models. So that this is the traditional model, but we could have a model where we begin to look at risk factors, symptoms, comorbidity, and endotype that drives the treatment process of OSA modality, match the patient to the specific pathophysiology, and then what could the therapy look like at the end. So that changes how we do this. It just makes it more specific and more personal. That's precision medicine. And that's what this begins to offer us. Last of the graphics here, but it just tells us a little bit more about taking these very things and being very specific about what we do from a mild, moderate, and severe type of patient down to understanding where the P-crit fits into all of these toward what sort of decisions we need to make. People are thinking about this, and that's exciting. And it opens up a different way for us to look at sleep disordered breathing and what we could do. And as sleep technologists, I'm excited about it. I don't see the threat. I see the opportunity. You know, if you're looking at getting a CCSH credential and you're wondering, and especially if you've looked online and you see people that say, oh, I got it and nothing happened in my life. Well, it's not a genie lamp. You can't just get your credential and magic things will happen. If that was the case, I would still be working nights as a respiratory therapist in Mobile. You make your own life. You've got to decide if you get that credential, you're going to make things happen. When you look at the people out there, like that Robert and I get to talk to on the podcast and are friends of ours that have taken the CCSH and made something of it, they looked at their market, they found a need, and they created something. They did. We have a friend that at one point in time, she represented 1/3 of the referrals to the sleep lab she worked for. That was above all the other doctors. And she was an RPSGT CCSH. Pretty incredible. No one told her how to do it. She just did it. She forged her own path. When we think about things like AI, it's how do you leverage it? How do you begin to inform yourself and get educated? It's just like when ASV and the FAAST technologies came out. If you really wanted to lead in the lab and be the one that got to do the complex titration, you had to step up. You had to learn it. You had to really get to know it. And in the labs that I used to go into all across the country, those people were the leading techs in those labs. And they had the opportunity in front of them that others didn't. So I think it all comes down to these things. We all have to work together when it comes to where we're headed, and we see that. And I'm sharing this with you today so that your ears are open and you're thinking about this and you're looking for these articles and these publications that can begin to inform you. And some of the names that I've dropped today are some of the biggest names in this space, and they're important to follow on LinkedIn and anywhere else you can. And it's just an important part of where we're headed. So I love this. It's kind of silly, but it's a great way to wrap this up. You know, I'm very excited about the future. And it's easy for me to say that as AST president, but at the end of the day, I get to see the good, the bad, and the ugly of this business. I remember when I first started in sales and I had to act like people who didn't know anything about sleep were amazing. You know, I had to go into their sleep lab and go, oh, that's awesome. Oh my God, you're an idiot. You can't say that out loud. You can lose your job. People frown on that. But you know, the reality is sleep is done amazingly well by the people that come to these meetings. That's the one thing I do know. The people that take the time to come to the national and state meetings are the ones who actually care and care about this field and want to continue to see it thrive. The ones who you see post online, where can I get my 10 free CEUs? Everything in me cringes, because guess what? Let me tell you something about that. The people that put CEUs together work. They're the actual ones that I talked about a few minutes ago that work 16 hours a day and volunteer and write up great presentations for people to learn from. They weren't free for them ever. And putting a presentation together is not easy. It seems like it, but it's not, because you want it to be meaningful and you want the people that hear you. Matter of fact, try doing it one time and see the response of the crowd. That'll fix you. You'll be like, yeah, I'm not doing that again. Yeah. How do I know? Yeah, it's been a crazy journey, but I want to wrap up, but all of this matters. What we do matters. And I hope that as you think about this career that we're in, that you continue to be passionate about it and begin and keep looking for opportunities. I mean, you know, and if you want to be inspired, yeah, it's a shameless plug for the podcast. We've had so many amazing people. We have one friend out of Buffalo, New York, who has a sleep store that she opened, and she actually goes around and does all of the sleep education for the emergency drivers in Buffalo, New York. She created an opportunity. I mean, when I could sit here and talk about people all over the country who are doing sleep technology in their way and their market the best they can. I mean, think about Project Sleep and what Emma's involved in. And, you know, we see everybody holding up the signs. I mean, that was a pretty viral thing of bringing attention to. Yes, that shirt. Thank you, ma'am. But it was a big deal. And I hope that when we even think about AI, you begin to start to think, how do I make this work for me? How do I empower myself? But at the end of the day, how do I help my patient? So with that, any questions? Yes. How can you get on the podcast? We can talk about this after. Anyone else? Yes.
Partially unrelated, but your wife's journey through her sleep care, as a AASC president and close relationship with the AASN, do you think that's one of the reasons they created that new hypopnea arousal rule, so that providers would have more options to treat patients who are just like her?
I do think that's part of it, but it's a journey. We still have to see, ultimately, we need to see that events can be associated with just arousals. You go across the border to Quebec, because I'm vice president of my company for Canada. And in Quebec, they do that. Yeah, the University of McGill, Dr. John Keemaw actually scores events with arousals, which opened up a whole bunch of people for a lot of women who could be diagnosed with OSA. And that's really, we need to see that shift. I mean, so it's a baby step in the right direction, but we definitely want to see a bigger step toward being able to have arousals as a part of that. So
and give our providers more options.
Providers more options, no doubt. Anything?
We used to do that in the old days, hypopneas with arousals.
Yeah, yeah. How things have changed.
No, right.
Then we invented CSS.
Right. All right. Well, thank you all. Emma, did you have a comment? Okay.
Do you think that all of the data we need to start really digging into EndoTypes and which group can fall into? Is all the data there in a PSG right now? It's just that you collect the data, or is it something that requires other things to be tested? Or?
Yeah, I think part of it depends on the company, or the platform that actually did it. And will the AI engine connect with that? So I know for certain companies that do AI like Knox and EndoData and others, they have that capability of pulling it and analyzing it and being able to give some of that information. So it's something to keep our eyes on, because all of it's there. It's just pulling it out so that we can learn more and be more effective for our patients. So.
I have talked to people here about people with narcolepsy who also got apnea and the business of diagnosis, especially if they have sleep apnea prior to the narcolepsy diagnosis. There's data within ESGs that can pick up on maybe extra random or something that could indicate that there's narcolepsy diagnosis.
You know, I think there's some AI platforms out there now that are talking about that. So it's not far-fetched to say that's around the corner. You know, the challenge of those are sort of like our discussion of arousals and events. The rule set doesn't favor that at the moment, but I do think that, you know, companies that are looking at this differently are going to be able to provide that information. But
there's one other thing, so there's a big difference in like the amount of time a person spends like in bed for ESG, as far as it's like the qualitative information that you get. Because I know some labs will have much later, some they don't necessarily have the exact amount of time.
yeah, that's a tough one to answer, because I mean, I think everyone in here would give you a different opinion.
Yeah.
You know, because
at least with narcolepsy, that the longer a person spends in bed beforehand, that actually the stronger the MSLT is for
Sure.
narcolepsy diagnosis, which seems counterintuitive, but maybe not, because the more arousals you have, then the, I don't know.
yeah, so yeah, I don't know if anybody wants to comment on that. I'm gonna leave that open to the table.
I'm fine.
All right, thank you all.